All right, so let's get started. So I would love to introduce our esteemed panelists for today. But beforehand, let me introduce myself. My name is Todd Shell Young, and I am the Director of Research at the Hub for Equity and Innovation in Higher Education at Georgetown University. And our panelists today, we have three, Dr. Christopher King, Dr. Tyra Gross, and Dr. Derek Griffith. Dr. King is the chair of the Department of Health Systems Administration in the School of Nursing and Health Studies at Georgetown. Dr. Gross is the assistant professor of public health sciences at Xavier University of Louisiana. And Dr. Griffith is currently a professor at Vanderbilt University, but as of July of 2021, will be joining Georgetown as the founder and co-director of the Racial Justice Institute here at Georgetown University. And in that order, I would like to ask our panelists to present to you for a few moments about their research as it connects to our topic for today.
Thank you, Todd Shell, and hello, everyone. Thank you for joining us. Let me share my screen here for you. Okay, we should be in good shape, right? Let me begin this session by sharing this timeline, this very powerful timeline. If we use 1619 as a starting point, we know that the policies and practices that legalized slavery and segregation were intact 83% of the time. It's going to take a long time to undo this damage, which has intergenerational impact. And I would argue that we're not even in the green zone, right? Think about voter suppression, think about mass incarceration, police brutality, and the significant racial wealth gap. And I think all of us, regardless of our professions, we come to work each and every day with the intent to do the right thing. But the challenge is the systems that govern our society, the economic system, the education system, criminal justice, and yes, healthcare. All of these systems are infused with and impacted by the racism in which they were created and maintained. So we're here to talk about healthcare, right? And I'd be remiss not to mention two texts that had the most influential role in my career trajectory. On the left, you see Unequal Treatment, which is a compendium of research investigations that corroborate that even when we control for factors such as insurance status, income, education, people of color are still likely to have a different healthcare experience. And in my own journey to dig deeper into the causal factors of this phenomenon, I read Harriet Washington's book, Medical Apartheid, and it tells the story of how Black and brown bodies were used for medical experimentation, all to advance the practice of medicine. And I think anyone who's interested in learning about, vaccine hesitancy and what needs to be done about it, this is a required reading. During that time, Blacks were received or perceived as inferior, as genetically different, unintelligent, having thicker skin, having a higher pain tolerance, and being predisposed to violence. These beliefs were institutionalized in the evolution of the American healthcare delivery system. And a few years ago, 2016, Hoffman, a Princeton researcher, and her colleagues found that some residents, med students, still think that there are biological differences between Blacks and whites. Differences in blood coagulation and skin thickness were the two most commonly cited fallacies. Even today, race continues to be perceived as a biological risk factor, but we know that race is a social construct. But despite this knowledge, race is still perceived and can be a key driver in clinical decision-making. We commonly see this in medical algorithms. We see this in disparities in pain management. And as I mentioned earlier, the healthcare system is a microcosm of a broader ecosystem, one that's built on implicit and explicit practices and policies that marginalize communities and individuals, restricting access to opportunity. Examples include Jim Crow laws, redlining, low interest loans for white families during the Roosevelt era, the New Deal era, just to name a few. And so, the bottom line is when people don't have access to high quality housing, high quality education, jobs with livable wages, not minimum wages, it's going to show up in our health status. And no matter where we go in the world, when one population has more access than another, health disparities emerge, and it has a very costly price tag because it shows up in preventable hospitalizations, it shows up in high readmission rates, late stage disease detection, and such as cancer and diabetes. And what about proximal access to high quality services? Recently, my colleagues and I, we looked at over 3,000 hospitals of all types across the nation and found that those with lower quality ratings were more likely to be in underserved communities and communities of color, and those with higher quality ratings were more likely to be in white affluent communities. So as I wrap up, racial inequality or systemic racism, it has an impact on the economy. And each year we're spending approximately $3.6 trillion on healthcare, which is about $9,000 per capita, a figure that is 2 times higher than other industrialized countries. And get this, right? Despite this exorbitant amount of spending, our life expectancy is among the lowest. As depicted here, you can see that we are pretty much off the charts when compared with other countries. The vertical axis shows life expectancy. The horizontal axis shows spending per capita. This trend is not sustainable, and I think it's something that should concern us all, because despite our race, despite our ethnicity, or where we are on the socioeconomic ladder, this is an issue that will impact us all. The country, I would argue that this country cannot fully achieve its potential without bold, courageous, uncomfortable, and intentional efforts to undo the damage. So I'll stop here and turn it over to my colleague, Dr. Gross.
Thank you so much, Dr. King. I really appreciate how you framed everything, and I gladly take the torch from you. So my particular slides today are going to reflect on the legacy of slavery, in particular for Black maternal health. And if you're not aware, it is the 4th annual Black Maternal Health Week. The Black Maternal Health Conference is actually going on as we speak. A mysterious castle set on a beautiful coast. In 2012, during my doctoral studies at University of Georgia, I had the pleasure of visiting Ghana, West Africa. My purpose was to immerse in a culture where breastfeeding was the cultural norm for Black women in preparation for my dissertation. On a weekend excursion, we had the opportunity to visit several different sites, including this building, Elmina Slave Castle. To walk the dark dungeons, to see the door of no return facing the ocean, and hear the story of slavery from the other hemisphere gave me a deeper perspective on the global complex legacy that is slavery. This legacy, in my personal opinion, has influenced every sector of society and undeniably has impacted how Black women in particular and their families experience healthcare around the world. King Solomon writes in Ecclesiastes that there is nothing new under the sun. Indeed, these historic photos serve as a looking glass foreshadowing our current times. Although Black women's bodies have unjustly birthed the field of obstetrics and gynecology and been used for medical advancement, we have not been privileged to special benefits, just the opposite. Black mothers like myself return to work the earliest, lacking maternity leave, paid leave, precious time required for postpartum healing and nursing their own children. Many of us are essential workers living in maternity care deserts, working right up until childbirth. Black fathers have been directly or indirectly removed from the family setting, causing additional stress and strain. The worry and concern of how our nation will treat our children contributes to high rates, if not the highest, of premature birth and chronic conditions before, during, and after pregnancy, and also maternal and infant mortality. Our families lack the generational wealth to fully thrive, and when we can, generational trauma, stealthy racism, and microaggressions taunt us on the daily. During my first pregnancy in 2015, I learned from a Native sister about the 7 generations principle. Before you make any decision, consider its effect on the next 7 generations. So if slavery was abolished in 1865, we are only about 7 generations or in that neighborhood removed. We're also in the middle of 7 generations. So if we think about the 3 generations before us and the 3 generations after us, we should be reflecting on 2 questions. What have we inherited and what will be inherited from us? Personally, I'm a storyteller. So my maternal great-grandmother, Eloise Piku, died in the 1930s due to childbirth, complications from giving birth to twins. My maternal grandmother, Dorothy, was the sole surviving twin. So just around the corner from where I have given birth to my own 3 kids here in the city of New Orleans is a family legacy of both maternal mortality and infant mortality. So while maternal and child health for many of us are our professional interests, this work is also deeply personal. A moment of silence. We cannot afford to lose another mother, another wife, another cousin, another neighbor, another educator, another lawyer, another change agent, mentor, researcher, physician. Their lives still matter and their deaths were preventable and their children and families remain with us. Healthcare globally must listen to Black women. Looking at these 4 core principles of medical ethics, autonomy, beneficence, non-maleficence, and justice, can contemporary healthcare confidently and honestly argue that they have been following its own guidelines? No. Instead, our maternal outcomes globally illustrate the lack thereof. Until modern healthcare fully course corrects, please know that Black women have already been on a collective journey of health and self-care. Resilience is in our DNA and we march onward still. This very week is Black Maternal Health Week, and President Joe Biden did sign a proclamation this week noting it as an observance. We are gaining momentum, but proclamations, annual observances, webinars, posts, social media likes are not enough. So our current generation and each generation has a choice. Whether we decide to be intentional and purposely build a legacy or simply drift aloof passively, we are building a legacy still. So are we going to turn a blind eye or not? We will have a sizable impact on future generations to come. So I leave you with this picture of the Black nesting dolls, knowing that we are already carrying future generations.
Thank you so much, Dr. Gross. And we'll have Dr. Griffith.
Help if I came off mute. Good morning, all. It is truly an honor and a pleasure to be joining you this morning and be joining my colleagues. Thank you very much to both Dr. King and Dr. Gross for setting the stage for me here. In my brief remarks, I'm going to focus on Black men's health in particular, but broadly try to add a little bit more, build on the foundations that Dr. King and Dr. Gross have already set. So I want to start, speaking of storytellers, with a quote that's probably very familiar to many of you, but I think illustrates what we're seeing now, and particularly as it relates to Black men, Black men's health. And honestly, and we chatted about this, the panelists and so forth, right before we came on, the struggle with trying to understand some of the recent events and experiences, the young man that was murdered the other day, like 13-year-old young man, Dante Wright being 20 years old. We're in the middle of the Derek Chauvin trial. And some of this, how do we explain that? And some of this speaks to this idea that these Black men are not really seen for themselves in their full humanity and in and of themselves. And so Ralph Ellison does a great job of characterizing this and capturing this in this particular way. He says, "I'm an invisible man. I'm a man of substance, of flesh and bone, of fiber and liquids, and I might even be said to possess a mind. I'm invisible, understand, simply because people refuse to see me. When they approach me, they see only my surroundings, themselves, or figments of their imagination, indeed everything and anything except me." if you think about the recent events and the challenges that we are faced with as we try to make sense of those kinds of events, particularly this latter part of this quote seems to really resonate, at least with me, that they never were seen for when they were approached, when they were engaged, they were not really seen. People saw themselves. They saw figments of their imagination, the fears of Black men that have existed for generations and that were rooted in the explanations that justified slavery. One of the things I wanted to add to what's been presented thus far is this idea that racism is not a specific event. It's not something that's an individual level factor, but it's a process. And the beauty of the image that Dr. King shared of looking at that timeline highlights just the different ways that racism is dynamic. It changes over time. It looks different in different spaces, yet the persistence of the patterns that you see are consistent. There's a reason that we've seen the same groups basically disadvantaged, and looking at the challenges as it relates to healthcare and health outcomes have been consistent since we've had these data in the United States, and that we've seen these racial differences persist over time. If we want to get into this, I hadn't included this before, but we do have a relatively recent book that chronicles this in terms of different populations. So I encourage you to look at that and to see if you want to get more in depth into these resources as well. When I talk about racism as a root cause of health inequities, again, just to texture a little bit what Drs. Gross and King have said thus far, we have the original issues of how do we explain and justify racism? I'm sorry, how do we explain and justify chattel slavery? And it was through our cultural beliefs, values, and how we frame this particular problem. So the reason that it was okay was because it was consistent with our beliefs about who Black people were, whether or not they were human. You had the 3/5 compromise and those other kinds of things that had happened where Black people were not seen as fully human. And that interrelationship with the economic system that was chattel slavery shaped our societal structures and foundations, and led at that time to inequitable opportunities for wealth, health, and well-being. When we fast forward to today through the timeline that Dr. King showed, little has been done. Yes, we've done things to try to essentially put Band-Aids on some of these strategies and approaches, on some of these challenges that we've seen, but nothing has really been substantively done to undo the structural advantages that came with some people being owned as property and some people owning those property. There's a accumulation of wealth that came with that over time, if you think about the ways that we think about wealth building, even within a person's life, if you have it and you're able to build wealth over the course of your life, it's much easier for you as you get older than if you try to start building wealth later in your life. And so that's the same principle that we're talking about here. Over generations, those things are passed down and those opportunities bear fruit in different ways as we move forward. And even though the structures arguably are not designed as explicitly to create inequities now, we still see those inequities building both on the fact that we're not addressing those fundamental issues and that we're not seeing these, and that we're still seeing those patterns of not having dealt with the original sin, if you will, or the original structural differences that created our system. I want to quickly just highlight also that I mentioned it briefly, that slavery was an economic system. And so again, it's important to kind of put these things in context, that it wasn't just about beliefs and values around who Black people were and so forth. It was the way that our society and our economy was structured and the foundation of it. And our foundation of our economy was built on the idea that one group had to be essentially the property and another group was the owners of that property. And that foundation, again, was not undone. So if you think about, if you put these pieces together, as I start to kind of put these pieces together, we have this definition of structural racism that really should help you sort of think about, if we think about healthcare and health outcomes, but we have to think about that in the totality of ways that our society disadvantages certain groups. So it's not, we can't just understand health outcomes by just looking at healthcare, access to care and so forth. You have to look at what's the accumulation of different disadvantages in housing and education, educational attainment, educational quality. employment, earnings, benefits, all these different other areas, and how that differentially affects resources. It's not just about differential attitudes and beliefs and so forth. It's also has to be focused on what are the resources that groups have as an advantage or disadvantage to address these issues. And so the playing field looks more like this than it does a traditional sort of flat playing field when we think about it in this way. Just to get to specifically the health parts, what I'm trying to contextualize and make sense of in my work is why do Black men, since we've had these data, Black men have had the shortest life expectancy of any race by gender group in our country. And the only other group that's sort of running neck and neck in this oppression Olympics, if you will, is Native American men. And their life expectancy tends to be roughly around the same point as Black men. We don't do as great a job in capturing their data at a national level, so it's harder for me to characterize that. We've also seen these things play out in the context of COVID, and we have this COVID-associated mortality that we've seen in the last year, and that Black men, again, even with something that was supposed to be the great equalizer of COVID actually affecting everyone potentially equally, we saw that Black men died at the highest rate of that, and we saw there, again, a cumulative disadvantage sort of come together. So without getting into the weeds of this, we've written a paper that sort of presents this and puts these pieces together in trying to understand this root of structural factors, this idea of structural racism, and how it's uniquely gendered, as well as there's a unique tenor and tone to anti-Black racism that we don't usually differentiate from other groups, and that foundation leads to higher rates of chronic disease concentration, particularly in Black men, higher rates of infection and mortality, or higher rates of mortality, at least, from COVID-19 and related issues, high rates of stress that come with the inability to sort of achieve success because you sort of have this one hand tied behind your back. And the COVID mortality that I was just saying, there's 3-year difference that we've seen relative to other groups, it leads to, that is the outcome of what we're seeing in just that particular example, that the roots of that particular example go back as far as we can characterize because the structures are so fundamentally different for these groups. I'll close with this. There's a quote that I'm going to paraphrase that says, history doesn't repeat itself, but it often rhymes. And even though racism doesn't necessarily look exactly the same, it doesn't play out in our lives, we don't characterize it in the same way that we probably did during slavery, it does have a certain song that is very similar and a certain tune that is very similar to what we're seeing today. Thank you.
Thank you so much, Dr. Griffith. Wow. If any of you are curious as to where do we go from here, I assure you that I completely understand the body of work that was just presented by our panelists. Incredible, very vast, and there's so many different directions that we can take this conversation. And thank you so much, Dr. King, for starting us off with such a very powerful timeline. When we think about the timeline, we think about slavery, we think of it as so far ago. But when we are contextualizing it in terms of years, whether that has to do with kind of the institutions and the structures of all these different things that we're talking about here, we are like, today is a blimp on that timeline. So we have a lot of work to do when it comes to healthcare, and how do we unravel, how do we unravel this history of slavery in our society, in our structure, so that we can truly move the health of all Americans along, particularly Black Americans in the United States. So one, I would like to also invite the audience to ask questions in the Q&A. There should be a Q&A symbol on the right hand of your screen. So if you'd like to start dropping in your questions, we will take as many questions as we can as we are having this conversation over the next couple of minutes. So thank you all so much for your questions in advance. So let's jump right in. So Dr. King, well, we're gonna go to the bigger kind of structural piece of this, the big vast umbrella here. the healthcare system. And when we're thinking about all these different approaches to population health, recognizing much of what Dr. Griffith just beautifully elaborated, we can't think about healthcare outcomes without truly thinking about what now health professionals call the social determinants of health. All of these different components of our lives that impact our health outcomes. Can you tell us a little bit more about the perspective from healthcare providers and hospitals and their efforts to help us work through these structural issues?
Yeah, thank you for that question. So let me begin by just saying that I come from that space. I worked as a health administrator and decided that it was time to be in a different space that allowed me to talk about real issues, right? Because in the healthcare sector, we talked about health disparities, but that was really code language for racial disparities, right? Racial differences in health outcomes. And at that time, and I'm speaking about 10 years ago, the health systems weren't ready for this conversation. They were not ready. It was very uncomfortable. Folks were not trying to go there in the boardroom. And so I ended up at Georgetown, right? Because I needed to be in an intellectual space that would allow me to help advance practice in a different way. And so the conversation has changed now, particularly this year, or last year, based on conditions and things that happen in this country that I don't need to revisit. But folks get it. They recognize that if we truly are going to do population health, right? And if we're trying to prevent readmissions, and we have payment models that are being developed now to keep people well, and or providers are being incentivized to keep patients well, you can't do that without addressing these issues. You can't do that without conducting critical audits of your community, of the way that you do business, of the way that you engage patients. And so the work that I've been doing recently has been working with organizational leadership, starting at the board level, helping boards really understand these dynamics. And you know, you can put these organizations on a continuum. Some are still in denial. Some are, you know, they're in the middle, they're like, and then some are more progressive, right? And I've been working with those organizations that are kind of in the middle and trying to figure out what to do next. So what I'm learning is that one, there is a desire to do some heavy lifting, but where do we begin? You know, like folks are really just like, it's so big, it's overwhelming. How do we begin this work? And so helping organizations work through their own journeys has been part of what's being done. There's no one canned approach, right? And so each institution, each community is different, and they have to figure out their own way. But it's wonderful to see organizations and leaders of boards that are really, really grappling in a different kind of way, right? In a very meaningful, constructive way with how to advance their population health goals with a racial equity lens.
Oh, thank you very, very much. And thank you so much for the work that you're doing. It is very critical to move these organizations along. A lot of people are they want to be progressive, but they're really not sure how to go about it. So it is very understandable that a lot of organizations are in that middle space. So thank you so much for your work in helping move them along. So we're gonna talk about the impact of Black women and Black men. We are to go back to that notion of moving the needle, right? We think about a lot of these issues in healthcare very theoretically. What do we do? What do we do? How do we propose to do something about, quite frankly, this crisis that we have on our hands? And honestly, I think it's about being on the ground, doing this work, integrating with the communities to truly understand what they're really, really going through. So Dr. Gross, can you give us a little bit more insight on the circumstances that Black women are facing, particularly as it pertains to resources that they are given to help them through the maternal process?
Thank you, Tasha. So in terms of resources, I think historically social capital has been very, very protective. So whenever we have these conversations, and I can see some of the questions that are being submitted, I think it's also important to not just look at risk factors all of the time, but to also look at assets, strengths, protective factors when we're trying to move the needle, because just trying to plug and play what other populations have done or what another country has done won't always work. So I think social support goes a very long way. There are, because of some of the figures that have been discussed around the lack of generational wealth, I think statistics say that Black families, in comparison to their white counterparts have, I think, like tenfold generational net worth than Black families, right? So that's a lot more resources that you have to work with, and your children have to work with, and their children have to work with in comparison to Black families such as ours. So when we look at the statistics, I think about, because right now there's been a lot of conversations around Medicaid expansion for the postpartum period. Medicaid covers a lot of prenatal care and childbirth experiences for Black women in particular. So I think Medicaid coverage, and a lot of times when politicians kind of talk about, what should be cut, there should be certain things that are non-negotiable, right? The WIC program that provides supplemental nutrition for pregnant, birthing, postpartum women and their children from 0 to 5. There should be certain programs that are non-negotiables. The SNAP program, also known as the food stamp program, these have been shown by longitudinal evaluation studies to be very protective. And what I think is interesting when we think about governmental resources and programs such as these is that many Black families, they've been using them for generations, or there is some broader stigma, but it's like, if I need the resources and I qualify for the resources, I would be silly not to get what can help my family. However, how they navigate the systems when they go to use their WIC benefits in the store, how are they treated when they go to use their Medicaid? Right now, I have a pilot project to look at some state level data. And I specifically wanted to focus on Black women and not do racial comparisons. We really need to get past that, but look at the variety within Black women's experiences across age, socioeconomic status, marital status, parity, all of these different things. And one comment that really stood out to me is a mother was trying to understand how come as a Medicaid participant, she had to sit in a different area, a different waiting room, and have different appointment time slots than the women who had private insurance. So even if there is some kind of scheduling system in place, outwardly, the patients perceive that as you treat me differently because I can only have appointments on these days and times. I can only see these providers. And that makes me feel some kind of way. I internalize that while I'm carrying another human being. So I think the data shows that these programs, such as Healthy Start, Nurse Family Partnership, a lot of these programs have had great long-term impacts and data to prove their reliability, their trustworthiness. But often they're the ones that are most vulnerable to being cut when it's time to make budgetary decisions by our policymakers. So I think expanding and protecting those existing programs, but also working with entrepreneurs to come up with new solutions, working with women themselves, right? Because we know that a lot of these federal programs, you have to fall with a certain level of the poverty level so there's some women that fall in the gaps there. But how can we have innovative solutions where women themselves can come up with solutions from their own lived experience to serve others and not, be dependent on whether this program is going to be sustained or cut. So those are just some of the initial things that come to mind.
Thank you so much. We are looking forward to the work that you're going to put out with this grant, and you are raising some incredible points, particularly about internalizing conscious or maybe unconscious, just kind of systems and processes or just experiences while pregnant or while carrying a child or caring for a child, even in hospital spaces. So when we're thinking about how institutions can be critical and fostering these injustices and these exclusions, sometimes it's very, very small things about waiting room issues that could totally be solved without taking much. You don't need a whole lot of money to, to solve a lot of these issues. And also to the point of getting women to start, or to help with helping to solve these issues too, right? Like we typically lean on the institutions to do it, but I believe that the institutions have a responsibility to bring the woman to the table to help come up with solutions from the women that they need, because they know their experiences, they know their needs, and that's really, really important. So thank you so much. Dr. Griffith, a lot of these issues, while typically men do not carry babies, they are experiencing a lot of the same injustices, and as you have already elaborated on. And when we're thinking about, okay, well, we are familiar with the work that you're doing and what your colleagues are doing, and we recognize that Black men typically are experiencing the worst health outcomes. What can we do to help with that? It's particularly as a lot of these institutions are moving towards this anti-racist framework, whether it is institutions of higher learning or even in hospital systems. What are your thoughts?
Yeah, thanks for a great question. Let me first just acknowledge that we're not trying to render invisible or exclude those who are non-gender binary. And it's really just a matter of pragmatics that, and the expertise of at least myself and Dr. Gross, if I can speak for you in this way, that we didn't want to just, basically not do justice to the issues that we are not as equipped to speak to. So I just wanted to start with that. I think some of what you're describing, there are a couple of thoughts that come to mind. One is, I do think that some of the issues as it relates to race and racism, that we have to think a bit deeper. I think the reason I was trying to show some of the model that we talked about in terms of syndemics and so forth is to really allude to and sort of highlight the fact that racism is not one thing. And it doesn't, the history of it looks very different for each population. It breaks down and the stereotypes and the other factors that affect Black women are very different, and just the way that we frame what racism looks like and the way that we culturally understand the experiences of Black women is fundamentally different than Black men. When we think about other groups and their experiences of racism, even if they're not necessarily racist. So we have pieces that talk about, Latinx populations and their experiences with racism because they're seen as racist, and we don't want to get into, in the interest of time, get into the weeds of all that. But I think it's important to look at things through that lens and to do what's called gender mainstreaming, which is basically the idea that you look at the gendered impact of policies and practices, and you look at, it's a kind of a variation of health impact assessment. It was popular some years ago. And it's really just saying that if you really want to understand how these things are operating, you have to look at the outcomes and who are they benefiting, and being sort of pragmatic and practical about, okay, how do we understand why certain groups are advantaged in this way? And what are the advantages that we're seeing? Can we quantify those? Can we actually come up with what those things are? And then as we work backwards, to Dr. Gross's point, identifying those differences are just the starting point. If you want to actually come up with solutions, you have to work from the resources, the opportunities, the strengths of the groups that you are actually seeing. And the comparisons are no longer terribly useful because you have to build from within the population that that you're working from. And so constantly comparing to another group to say, well, they're not like this, they're not like that group and what have you, is not helpful because those aren't the solutions that are going to be successful in that particular space and population.
Thank you so much for answering that question. Before we kind of go to the audience, as we have a little bit more time, I'll try really hard to ask all of your questions. But before we transition into audience questions, I have one additional question. So Dr. King and Dr. Gross talked about the historical legacy of healthcare in the context of slavery, particularly with the medical apartheid, which is, I completely agree, it is required reading. And it really highlights the impact that and the traumas, all the above that Black people have endured for the sake of advancing medicine. So when we're thinking through that, we also recognize that this is not solely an American issue. When we're thinking about slavery, slavery is an international phenomena. So what are your thoughts about, taking this conversation and contextualizing it in a global context so that we can really start knocking down these barriers to healthcare among Black people? And anyone can take the question.
I'm sorry.
Oh, go ahead. Yeah, go ahead.
I'm sorry. My global health students, my senior undergrad class, their book club for this school year was Medicalizing Blackness by, I believe her name is Raina Hogger. And so really kind of talking about how in the antebellum South and in the West Indies, on the slave plantations, how, masters and physicians would tinker with Black people's bodies to try to really understand how to keep them healthy, but for economic reasons. And so a lot of the history of medicine goes back to some of these early unethical studies that were done on the plantations. And that has just gone abroad into different settings, into how people have been trained, going back to the pain tolerance. And even one person critiqued that the artist that painted Lucy and the other two ladies with Dr. Marion Sims, it's like, do you really think that they were just sitting on the table still and not fighting back when they know that they were about to be, abused? So I think when I have been interested in looking at Black maternal health outcomes in other industrialized nations, as well as other countries that don't have as much resources, as because I understand that sometimes they have some practices that we can learn from. Shout out to Cuba, shout out to, I think it's Sri Lanka. So we're seeing the same narrative come from Canada and come from the UK around Black maternal health, even though they have socialized medicine and everybody has health care. Like, it's not, you don't have it, like you have it, but still, how are you treated once you access it? So those are just a few things that I can think about when we look to our other industrialized neighbors. We're seeing similar phenomenon, even if it's not as complicated or as worse here, but sometimes they don't even categorize race to look at the differences the same way that we do here.
Thank you. Dr. Griffith, did you want to?
Yeah, I was just going to quickly add that if you think about the concept of race and which countries have it, it's usually countries that have a history of chattel slavery. It's not a universal phenomenon. There's a reason that most other countries use concepts like ethnicity, indigeneity, and those kind of factors to characterize their population, class, and so forth. So if you want to understand sort of race and racism, you've got to understand which countries have tried to categorize people and quantify their, and look at them and be able to use that. It's not, the last quick thing I'll say is, it's not an accident in our country that it's the US Office of Management and Budget that actually sets the racial and ethnic categories for the US. And that it just so happens that those categories are the ones that magically manage their way into electronic medical records, into health and healthcare, and so forth. So even though I'm sure health professionals will say, well, we don't know, we don't look at that and so forth, there is this idea that we're taking these things that are in other aspects of our life and other structures within our society and applying them to healthcare in ways that we have to really critique and better understand.
And I just want to add, that speaks to the whole systemic piece that we talk about, right? It's big, and that's what we're trying to get healthcare leaders to recognize, right? That it's not just an individual thing, right? This is a big systemic issue. And these are specific examples of how we've been doing our work for so long that continue to perpetuate the problem and continue to disengage people of color from the healthcare delivery system, right? So.
Thank you all so much. All right, here's our first question from the audience. What role do institutions of higher ed play in the perpetuation of these legacies? What changes do universities need to make in order to support substantive change change in the healthcare system?
I think denial. I think, and when there's lack of awareness of these issues, then we're doing a disservice to our students. We're not delivering a world-class education. I think it's important for universities to conduct, again, these critical audits of the names of buildings, right? And the curriculum, and what about faculty? You know, do faculty have the skills, the competencies to address these issues in their courses? Are we critically auditing our courses, right, with a racial equity lens? And so if those things aren't happening, then that's my response to your question, right? And so it's really important for us to have this working knowledge of how this shows up each and every day. And I want to say our students, from my experience, our students are thirsty. They are asking for this, they need this, they want this, the world needs this, and it's incumbent upon us to deliver. And I think that's the journey that I know that's the journey that we're on right now. I'm really proud to be a part of what's happening on our campus.
Thank you so much for answering that question. Dr. Griffith, would you like to also chime in?
Well, just quickly, I would say the other thing, again, sort of playing off of this idea of looking at data, we have to sort of ask ourselves, if your student population doesn't represent the larger population, and you're actually seeing, you know, and you've always sort of seen this historical pattern where certain groups are underrepresented in your student population, underrepresented in your faculty, that you've got to look at that more seriously and think about, well, is it, you know, and you know, a lot of times we'll explain it away as, oh, they didn't apply, or, oh, they weren't qualified for this reason and so forth. Well, sometimes actually they are qualified. Sometimes it actually is the criteria that you're using to decide who's qualified. It's the criteria that you're using to retain faculty, or to keep, or to hire the faculty in the first place. So I think we have to look harder and not just sort of blame the victims when we sort of see these issues and just always explain it away as, well, it's the flaw of those particular groups and it's their fault that they're not doing whatever it is.
Thank you so much. All right, we'll go to our next question. What are some ways that white allies can help to make tangible changes in the healthcare system?
When we were having this conversation in preparation for our panel today, we kind of talked about the term ally is very, very popular right now. I think it's very, and no disrespect to the person that put it's a safe term. So I think there are some people who only want to be allies. And then there are people who like, well, I would like to move from being an ally to be, I think what I was saying, like a deep trench advocate, like, you know, I'm willing to put myself out there more. I'm willing to speak up more. And I think really it starts with true empathetic listening and not trying to lead. I think that also goes back to the question about higher ed, is some institutions have been wanting to lead all of these efforts without having the proper knowledge and resources or players for these conversations, but because of power dynamics, they want to be front and center. So I think allies need to kind of really be introspective to say, what is my true motivation for even wanting to be an ally? Is it because, check on social media? Is it because I genuinely care about people? Because you cannot move from being an ally to being an advocate unless you truly care about people. Like we talk about economics, and sometimes allies, that's the language you have to use. Sometimes you have to use economic terms to get people to even kind of care, which is sad. So you have to be creative in your language, but you also kind of have to ask yourself, what is my goal as an ally? Is it to just be an ally? Is it to move beyond just what I'm comfortable with or what's socially the norm right now? And a lot of this hasn't been displayed well for people who may not be Black and want to be advocates for the Black community. But I would say, listen. Don't try to lead, listen and genuinely form relationships and friendships and have empathy and care. And that goes for educators K through 12 when they're working with young Black children and how they discipline them, how they educate them, and also for those, whether it's your patient or your patient population, that you're working with, really checking your biases. So unconscious bias training would be highly recommended for us. Look at the questions that are coming in. Unconscious bias training, because we all have biases, right? We all have been reared in a society where we have these stereotypes and we use them to try to keep ourselves safe or kind of navigate different situations. So it's not that it's always bad, but when you know that you have the bias, you can actually I guess, mediate it and try to figure out a way to navigate it so that you're not causing harm from that place.
Thank you so much. Did anyone else want to quickly chime in?
Yeah, I can quickly just add to that. So I think white allies, the first thing to do is recognize the power that you have in the system that you're working with, and to utilize that power to hold your white peers accountable and to check them when these kind of issues come up. We don't need you to be really impolite. The focus should not necessarily be, in my opinion, and just in my opinion, on necessarily working with and in Black communities. There's a space for that, but it's also needing to organize, educate your white peers, your white colleagues, your family members around these issues and address those kinds of issues. It's much safer to come and to try to lock hands and arms with your Black colleagues and other marginalized groups, but it is more important in some cases, and we're really at a place where we really need colleagues to be able to do that. What I was scribbling around for and was looking, off the screen for was a piece that I wrote with Heather Kane in 2018 that talks about the roles of white allies and some of the things that can be done in that space. And so that was sort of what I was doing. I wasn't being disrespectful, at least not on purpose. The last thing I'll say quickly is that you also have to learn how to hit people in the head, not in the heart, not just in the head. Thank you. So you have to figure out, a lot of these things are heart issues. It's not enough to just change people's mind and mindset, because there's something deeper about this. Racism and the idea of being racist has deep meaning for people, and what that actually connotes to folks is really painful. And even if, it on whatever side that you're on, that term it has emotional resonance in some way, shape, or form. So you have to really be able to deal with that. And so the arts can play a key role in helping to open those conversations, open those dialogues, help people see others' perspectives. So that would just be something really important to consider.
Thank you so much. Wow. So as I started this Q&A session with the question, where do we go from here? While there are so many questions, and I apologize for not being able to ask them all, but I want to connect a few for this final question. What influences your work? And what is your advice for everyone who is watching this session to help move healthcare forward, to ensure that the systemic issues are broken down, eliminated, so that Black people, people of color, and everyone around the world can have better health outcomes? Let's start in the order of our presentations, Dr. King.
So I think what moves me and what gives me, each and every day is my own family and what I've seen just growing up and in the community that I grew up in, knowing that the system and the way it has been intentionally designed has disenfranchised people and has led to premature death and mortality, morbidity. I think that moving forward, what's important is that we are, and I know some people love this term and some hate it, is that the term woke, right? Really, and what folks mean by that is really being aware, consciously aware of the injustices that happen each and every day in communities and neighborhoods and people's experiences, right? Just having working knowledge, and each and every one of us needs to navigate, move about the world. We talk about global, like move about the world with that level of awareness and think about our own lives and our own spheres of influence and how we can use our lives to move the needle. And so I'm glad that you mentioned the piece about allies, and I talk to students, white students who are struggling, like, what do? I don't want to say anything wrong. And so it's important for us to create these spaces for meaningful dialogue, constructive dialogue, so folks are comfortable in engaging in these conversations in ways that are healthy and will move us forward. So thanks for that question.
Absolutely. Dr. Gross?
So what influences me, and I did see someone asked about working at a Catholic institution. So it's not the Catholic institution so much as I was drawn to the social justice values that Xavier has, and Xavier here in Louisiana is an HBCU. So being a gifted and talented Black young girl growing up in Baton Rouge, Louisiana, I was kind of one of the only. So navigating white spaces, I feel like I definitely have that Scouts badge. Like I'm used to being one, if not the only Black woman in a predominantly white space. And so I have a level of comfort that some of my counterparts have not had. Going to predominantly white institutions, LSU, University of Georgia, doing my postdoc at University of Texas Medical Branch has helped me have a perspective that I want to mentor especially the next generation of Black students, Black researchers, Black doctors, to be in these spaces and to know that they can take up space there and that their perspective is much needed. And so my faith does play out in that, and that's why I kind of dropped King Solomon on y'all for a little bit. But yeah, I think just my lived experience, and now I will say I probably had a lot of elitism before motherhood, but once I was like, oh, wow, I have way more compassion about, the subject of Black maternal health now being on the other side. And it's funny that you can see the picture in the background because normally I have a Zoom filter, but I was like, you know what? It is important to acknowledge that you can't just take off your personal experience as a researcher. And I think that's also where research in medicine tries to act like we're separate. Our professional lives are separate from who we are as individuals, and you can't just take that off. You can't just blind from your lived experience. So yes, just my own walk of life, my own family, my own community, and seeing things and feeling like this should not be in modern times. This should never have happened, and really having a social justice heart for having people be well.
Thank you so much, and we will have Dr. Griffith close us out.
Okay, thank you. Quickly, similar to both Drs. King and Gross, it's my family, and honestly, I feel called to do this work because this is where I don't know what I would do otherwise, that I'm not very good at much else, so I just have to do what I can do. I think as far as what to do next is to really be courageous and thoughtful about what you can do. What are the things that within your purview to do? We're not trying to make anyone responsible for slavery. We're just trying to highlight the depth, the complexity that is the problem that we have today. We know that you didn't own slaves. We know that you didn't, you weren't responsible for that. That's not the point. The point is that that we have a society that was built on that foundation that we have to then figure out how to navigate going forward. So thank you.
Thank you all so much for joining this session, and we hope that you've enjoyed it. Thank you to our panelists, and we hope that you all have a fabulous rest of the conference. Have a good one.